Yeah, thank you all for coming on this Friday. This is a topic that's very important to all of us, and especially as a lot of us are independent practices and managers and owners, administrators. And so we're just excited that you're interested and you're participating, as well as we would just want to thank Nathaniel for his willingness to come and share to us today. Um, so without further ado, let's just virtually welcome Nathaniel Aranya.
Hi there. Thanks for having me. So, a little bit of my background. Um, I started in the out-of-network billing and collections field many years ago. That was over 15 years ago. And as you know, out-of-network is something that's changed and transformed into something very different today. It's not as prevalent as it was. And many clients have realized that, hey, I need to get in network contracts. And so I started NGA Healthcare a little over 12 years ago. And we started negotiating on behalf of practices and medical businesses. And what we found is that many of the practices for which we negotiate for hadn't negotiated their reimbursement rates in many years. And so we started offering it as a turnkey service to clients in addition to some credentialing. But again, we found that many practices hadn't negotiated their reimbursement rates. Their rates, because of inflation, were uh, uh, unfortunately. And here we go. We can share the. We can go to the second slide. There we go. Just a little bit of background about me. And again, starting in the out of network and then moving on to starting NGA Healthcare about 12 years ago, where we started negotiating reimbursement rates on behalf of a number of different practices. And when we started doing this, it wasn't very prevalent for groups to negotiate their reimbursement rates. We kind of pioneered that concept and started representing a number of groups and surgery centers to negotiate their reimbursement rates. And go to the next slide. So it begs the question, why should you negotiate your reimbursement rates? Well, if you consider that every year you're losing anywhere between 2 to 5% due to inflation, that means if you're not negotiating, let's say, and you haven't negotiated in 3 years, well, you're anywhere between 6 and 15% or excuse me, 9 and 15% of where you were 3 years prior. And that's a difficult pill to swallow, so to speak, because we know that in this inflationary time period that we've had, that inflation has actually, in fact, been a lot uh, bigger than it has been previously. We know that uh, uh, clinical and administrative staff are demanding wages that are 30 and 40% higher than they were just a few years ago. And with good reason, of course, because we all know that everybody is paying a lot more at the grocery store, a lot more for insurance, a lot more for every single sort of uh, service that they need. And the issue with that is that unlike a grocery store or other businesses who can simply increase their rates, increase what they're charging, medical practices, surgery centers don't have that benefit. They don't have the ease of just turning to their patients and saying, "Hey, the costs have gone up, and we need to increase our prices." They actually have to go and negotiate their reimbursement rates with each of the payers in order for them to get more. It's not like a knob that they can just put the dial up and be able to cover all those increased costs of doing business. So in no other industry does that occur where you're so beholden to a certain rate that you can charge without any consideration for the inflation that we're experiencing without the increased costs of getting clinical and administrative staff. So it's important to be able to negotiate your reimbursement rates on a yearly basis, not just initially, but after you've initially negotiated them, you should be negotiating them every single year to account for that inflation, to account for the increased costs of doing business. Let's look at examples of large health systems and large hospital systems. We know that they're getting reimbursement rates of 300, 400, sometimes 500% of Medicare. And that's in very stark contrast to what a lot of smaller and medium-sized independent physician groups and surgery centers are getting. We know some of them are getting sub-Medicare. We know that some of them are getting below Medicare rates. It used to be over a decade ago that your reimbursement, as compared to Medicare from your commercial payers, was actually higher. On average, it used to be about 120% of Medicare for commercial reimbursement rates, and Medicare again was the lower paying payer. And now we've seen the opposite occur to where a lot of the commercial plans are reimbursing sub below Medicare rates. And somebody brought up the question, how long should your contracts be for? The majority of them should be around a year, renewing under the same terms. There are some of them, particularly United Healthcare, sometimes Aetna, they will give you contracts that are longer term, let's say 2 to 3 years. And what you should do in those circumstances is you should negotiate and build in cost of living increases that should automatically be employed as soon as the contract renews. So let's say we negotiate an Aetna contract that's a 3-year contract, and we go from 90% of Medicare to 110% of Medicare. Great. Well, what about the prevailing years? Well, what we have to do is we have to work it into the agreement that on year 2, we're going to have a 3% increase. Year 3, we're going to have a 3% increase. And what that does is it allows you to work those increases in without having to negotiate every single year, which is good. We certainly advocate for that, but knowing that it's not necessarily feasible, and sometimes these are just 1-year agreements. Um, I do want to also talk about how private equity influences a lot of the healthcare landscape and how that's affecting a number of our clients, because we've seen it in the field. We've seen it occur. We've seen how it's impacted the healthcare landscape. Private equity was always a small player in healthcare, but now they're realizing that, hey, if we come in and we buy a bunch of these practices, we're probably going to have a lot of leverage against the insurance company. And while that may be true in some circumstances, it's not always true. It Sometimes the health plans themselves are a little bit more reticent to negotiate with a private equity company because they understand the ramifications of doing so. So if you're a dominant player in a market that's backed by private equity, the insurance company realizes that, hey, if these guys get any larger, if they get any more profitable, we're gonna be in a little bit of trouble because they're gonna suddenly have quite a bit of leverage against us in negotiating.
Mm.
So that means that's a good thing for the smaller and independent practices, because that means that they are more willing to negotiate with small to medium practices, because they don't want to continue to see the amount of consolidation that we're seeing in the market. They understand the ramifications of that. So that's why I highly encourage any sort of practice to be negotiating their reimbursement rates, whether you're a one provider practice, whether you're a 50 provider practice. The health plans are willing to work with you to do it. But again, it just takes giving them a value proposition, showing them how you're different, which we'll get into a little bit later. But the other thing that I did also want to talk about is with respect to private equity and private practice is this idea of what I like to call the law firm model for physicians, where we typically have a single specialty, although sometimes a multi-specialty group that brings on associate physicians, has partner physicians, and what they do is they treat these new associate physicians didactically. They train them, they become their mentors, and eventually they go from being associates to being owners in the practice. And oftentimes, the older physicians will retire and sell their interest in the practice to the younger physicians and or associates who eventually become partners. And the reason that we like this model is because again, it's physician owned, physician driven, and it allows for newer physicians to have some kind of a an opportunity to enter into a career um, destiny, so to speak, where they're going to be able to own the practice eventually. And again, the decisions are made by physicians. It's not corporate practice of medicine. Typically, it's in the best interests of the patients. Those are the types of practices that we like to see that are preserving private practice. They're bringing together synergies and uh, coming together to not be owned by large private equity groups who aren't necessarily making decisions in the best interests of the patients. Oftentimes, we have physicians that come to us that have joined private equity or have sold their practices to private equity, and they always tell us the same thing. Well, we thought it was going to be different. We thought we were going to like this model. We thought we were just going to be able to practice medicine and not have to worry about the business side. And while that value proposition sounds promising, it doesn't always materialize that way. Oftentimes, the goal of private equity is to try and extract as high of a profit as possible, sometimes at the expense of patient care, and that's not a good formula for anybody. We can go to the next slide, please. So here I like to talk about how we spend the most. We spend the most out of every other country in the world with respect to our healthcare, and it begs the question, why do we spend more? Is it because our healthcare is better? Well, we could certainly argue that we have, very well educated, very talented physicians and providers within our system. But the problem is that they're not the ones that are charging the most. We know, going earlier to what we were talking about, these hospital systems, we know that these hospital systems are the ones that are getting reimbursed the most. And that's why it's so important to us to negotiate reimbursement rates, and why we represent a number of clients who are trying to do the right thing and take services away from the hospital and put them in surgery centers, put them in an office-based setting. A very good example of this is the vascular field. Vascular used to be a very hospital-based uh, specialty. You used to never really see a vascular surgeon outside of the hospital. Well, we've figured out through, innovation and technology that we can provide a number of procedures in an office-based setting non-invasively with a vascular physician. They typically just take a wire and a lead, and they can run it through your body, and they can do thrombectomies and unclog arteries, and it's amazing what they can do very safely in an office-based setting. The exact same procedures that if you were to have them done at the hospital cost 50, 60, $70,000, whereas these exact same procedures can be done in an office-based setting for a fraction of the cost, sometimes 12, 13, $15,000 as opposed to, 60, $70,000. So it's a big advantage and it's a big difference. And patients prefer to go to the office for these procedures rather than having to go to the hospital. Next slide, please. So the other question that we often get is, where is all this money going that we're spending? Well, what we can tell you is that there are some very large incentives for a number of these health plans to get what are called self-funded groups and administrate their benefits. Now, what is a self-funded group? There are two types of insurances that insurance companies provide to employer groups, and one of them is just a regular run-of-the-mill insurance policy that you pay a premium per employee per month. The other type is what's called a self-funded plan. Now, a self-funded plan is where a business, typically they're around 50 employees or larger, they take their premiums that they otherwise would have paid for to the insurance company and they pool them within themselves and they create a pool of money. And from that pool of money, they pay out claims. Um, sure, they have an insurance policy if they go above the money that they have in this pool, but for the most part, they're paying out their own claims. And this is something that is protected by a law called ERISA, the Employee Income Security Retirement Act. And what this law was created to do was it was actually an old I don't know if anybody remembers the old well, may not remember it, but may have heard of it, the old Studebaker cars that they used to build in the United States. They had a retirement plan for their employees. When they went bankrupt, come to find out, that company was taking everybody's retirement monies and was using the money. And so suddenly there were thousands of people who were, number one, out of work, but also had all of their retirement just wiped out. It had been spent by the company. So the federal government implemented this law to
And your card.
uh,
Try to finish
the
my.
protect the
I'll get over now, okay?
monies that are meant to be spent on employees, including health benefits, retirement, whatever it may be. And part
Wonderful.
of that is that they
So I'll
have
see you on
to.
Monday at time for Eddie. Yeah.
Oh, sorry about that, guys. We had a little bit of feedback. So the idea behind that law was that we need to protect the money that employer groups are paying for these employee benefits. In other words, we can't just, spend the money that we're saving on behalf of these employees, and we have to act in the best fiduciary interests of these employees. So what does that mean? Well, that means that insurance companies should be working with providers, small to medium providers, to ensure their longevity, to ensure their prosperity, because these are the providers that are going to be able to provide the services at a reasonable rate as compared to a number of these large hospital systems. Okay, we have one comment where somebody's saying, we are a very small practice, two providers, and are finding the insurance companies don't care about us. They feel they can easily absorb our patients somewhere else and offer us nothing. It's very frustrating. I agree. It is very frustrating. Um, I will say that one of the strategies that we employ is the squeaky wheel gets the oil. You're right to say that they don't care about you because it's very easy to get that sense, but it begs the question, who do they care about? Well, they care about their relationships with their employer groups. Um, I'm going to sound a little bit like a Debbie Downer for a second, but insurance companies don't really care about physicians. They don't really care about patients. What they care about is their employer relationships. So anytime that you can empower your patients to get in touch with their uh, uh, employer groups with respect to a negotiation is actually a good thing. I'll give you an example about this. We were discussing earlier about the importance of self-funded plans and how they have to treat their patients or employees in the best manner possible. Whenever you terminate with an insurance company, the insurance payer has to notify every single one of their self-funded groups that they are in fact going to go out and network with you as a provider. And that's what often gets the patients upset, especially if they've been coming to you for many years. They go to their HR, they say, hey, I learned Blue Cross or I learned United is no longer going to be in network with my uh, rheumatologist that I've been seeing for the past 10 years. What's going on, and that would prompt your HR to get in touch with um, your insurance carrier, and that's what insurance carriers don't like and don't want to see. So it is frustrating to feel like they don't um, care about you, and I certainly can sympathize with that. But that just means that you have to employ other strategies to get their attention, whether it's utilizing your patient's HR, whether it's just continuing to be a little bit tenacious and continuing to be the squeaky wheel, and showing them, hey, these are what my competitors are getting in other markets. That's what can really potentially move the needle. Um, I don't want to say that, hey, the insurance company is going to automatically do it, but what we can say is that um, they are more willing to work with you if you continue to uh, uh, be that squeaky wheel. Uh, let's see. Somebody's asking, lots of my patients have self-funded plans. How do I get in touch with their HR department, or does the patient know who to go to? Very good question. Very often, I would say 99% of the time, the patient knows exactly who to go to. Every single one of these self-funded plans have what's called, and it's required by law, a plan administrator who has that fiduciary responsibility to ensure that the health plan is running things appropriately. So it's typically an HR person who is named as the plan administrator, and it's not you as the physician who would get in touch with the HR person or plan administrator. You want to try and motivate your patients to do that because they're the ones that can better affect change, especially if it's a large employer group. Um, if you can go back, let's see, 2 slides, Cameron. I did want to talk a little bit about, or I'm sorry, yeah, this slide. Yep. Okay. Um, bear in mind that these large employer groups that are self-funded, they're paying kickbacks to the brokers that are getting these uh, uh, health plans and clients to the tune of sometimes hundreds of thousands of dollars. So you can imagine how much money is associated with a number of these uh, self-funded plans. And the other thing that we also have to realize is that a lot of these health plans are very vertically integrated, meaning that they have pharmacies, they have pharmacy benefit managers, they have their own practices. So again, we're working up against a large conglomerate, so to speak, of of um, of health plans that own a very large part of the healthcare business. Let's see, we have another question. Can patients affect change mid-year or only when contracts are being negotiated? You can negotiate your contracts just about at any time. There are some health plans, for example, United Healthcare, who are a little bit more difficult to try and negotiate the reimbursement rates mid-cycle, is what we call it. But many of them will negotiate mid-year, especially if you haven't negotiated in many years. And oftentimes, what we recommend is we say, well, if you're not negotiating at this time, let's at least do a negotiation on what the rates will be come when the time comes for our contract to actually renew. The other strategy that, and you can go down 2 more slides, Cameron. The other strategy that we like to employ is, and highly recommend that providers really understand, is the level of granularity when it comes to negotiating each and every single CPT code. As an example to this, we one time worked with a neurology practice who was negotiating their reimbursement on their own. And they came to us and said, well, we're in the middle of negotiation. We don't feel it's going well, although we did get a 10% increase from United Healthcare. And I said, well, great, let's look at that offer from United Healthcare. And bear in mind, this was a neurology practice. Well, come to find out, they lowered all the neurology practices. They thought that CPT codes, they thought that they were getting an increase, but in fact, they were just increasing codes that the practice never used. They were increasing ortho codes, cardiology codes. So it was in fact an increase, but not on the utilization of the actual codes that they were using. So that's something that you really have to watch out for when you're negotiating your reimbursement rates. What is the actual financial contribution of each of the CPT codes that we are utilizing? And again, we have to do it on a granular level, because sometimes they'll raise a code, sometimes they'll lower a code. But some codes, if they have enough utilization, it's okay if they lower it. Versus another one that if they do increase it, okay, well, this has a larger financial contribution to our bottom line. Here's a question of how the new House bill, tax bill, will impact our reimbursement rates. Well, we know that there's going to be possibly cuts to Medicaid. We know that a lot of Medicaid patients are going to be taken off of the Medicaid system, and it begs the question, where are they going to go? Do we think they're going to go to the commercial plans? Are they going to go to the marketplace plans? Nobody's really sure. Will they just forego coverage altogether? That's a possibility as well. I don't see the tax bill having a direct impact on commercial rates. Could it possibly have an impact on Medicare rates? And the answer is yes. That's a very real possibility. We negotiate reimbursement rates for Medicare all the time, and if there is an impact to Medicare rates, well, that just means that we need to make sure that we're negotiating off of Medicare that's from the correct year. In other words, we may go to one of our payers and say, hey, I don't want 2025 Medicare, or let's say 2026 Medicare that is lower. I want to go off of the 2022 Medicare rates. So that is a negotiation that can be had, and it is something to consider when we know that there might be cuts to Medicare reimbursement. Okay, and somebody asks, do you recommend starting the conversation with select codes or asking for an overall fee schedule increase? I prefer to really know the numbers before I enter into a negotiation. Um, I don't want to just say, hey, I want a 10% increase. I really like to understand what each of the CPT codes are reimbursing before we make an ask. And understanding that is paramount to the negotiation, and also understanding what your competitors are getting. It was about 3 years ago that hospitals were required to publish the amount of reimbursement they were getting for the majority of their services for hospitals from each of their payers. A couple years later, health plans were required to publish the exact same information. And what that meant is that we had the reimbursement of every single physician in this country, and we can understand where are we in comparison to the market. Now, when the health plans released that information, they obviously didn't make it easy. They didn't want it to be um, easy for everybody to just see what reimbursement rates were, because I think it would shock, the majority of people to see the price differentials for the exact same service. But we have a lot of very talented companies out there that were able to parse through the information. They were able to extract the information that we need. And we as a negotiation company have that information, so that when we enter into a negotiation, we know exactly what our competitors are making and we know what the market can bear. And that makes the negotiation, I think, a little bit more successful. And as part of this webinar, we have agreed to do those extractions for anybody on this call or anybody that subscribes uh, uh, to this organization, because we want to be able to offer that as a service, to be able to show you what your competitors are making, and where we think there's a potential for you um, to land. We can go to the last slide, Cameron. This is our information if you want to have that analysis done for you. Um, and you can obviously use this QR code to sign up for that rate review, or you can email Cameron, who's on the line, who can set up a time to give you a free consultation, or to provide that rate review for you. All right, and so at this time, I'd like to open it up to any other questions that anybody has. Let's see. Somebody's asking about a Betos-based contract with Blue Cross Blue Shield. I'll be honest with you, I'm not familiar with it, but it's something I'll look into.
Nathaniel, could I jump in and let's say there's an independent practice or a small practice that's never done this. What first steps would you recommend for them in regards to preparing for negotiations?
The first thing to do is to put together your value proposition. How are you different? How are you saving the system money? How are you improving the patient experience? If, for example, you keep some time slots open because you want to make sure that a patient who would otherwise present to the emergency room instead comes to you, well, that's something that you want to point out. How is your training and your specialty? How does it impact uh, stopping hospital admissions, stopping ER presentations, stopping downstream costs, doing case studies that show them, hey, because this patient came to me and didn't go through the traditional modalities and episodes of care, this is how much you saved. Having those numbers, having a good argument in place is the first step. Somebody's
Thank you.
asking, TriWest would be able to, as a government agency, would they be able to be negotiated? The short answer is yes. Will they go above 100%? Typically not, but a lot of these Tri-West contracts, they've been slashing the rates on them. They've been trying to unilaterally go down to 70, 60% of the Tri-West fee schedule. Um, you have to have some pushback. You have to, especially if you're of a specialty near a military base, if you have a large Tri-West population, you have a little bit more leverage because a lot of these service members are losing access because of the number of slashes that they've been doing to Tri-West, but you can absolutely negotiate for these reimbursement rates. All right, somebody's asking, there are a big few hospitals, integrated systems in our area, and I've heard from a few practices that insurers respond to negotiation efforts with, we can't raise your rates. ABC Healthcare put a gun to our head, and there's no room left in our budget. It feels like an impasse. But is there a possible way to respond? That's a good, question. And sometimes they do say, yeah, we can't raise your rates. Very seldom do you go to the health plan, ask for a rate increase, and then automatically get one. You have to, again, be that squeaky wheel. Sometimes you have to go back to them, on a weekly or a daily basis, even though they're saying, oh, we can't do it, we can't do it, we can't do it. They can do it. And you have to understand that the increases that you're asking for, while they are very meaningful and impactful to you, it's just a drop in the bucket for a lot of these insurance companies. And it's just a matter of getting them to come to the table. And once you get them to come to the table and be persistent is where we see the most success. Okay, somebody's asking, they recently received a contract from UHC that included this clause. Providers shall submit to UHC a current annual financial statement within 90 days of following the close of provider's fiscal year interim financial statement upon request by United. What is this about? Is this a common requirement with insurance companies, insurers? No, I don't often see that. I think that that's overextending their scope of what they need to know. They shouldn't need to know what your finances are and what your financial statements are as a practice. And I'm glad that you did not sign that contract, Monica. Can you talk a little bit about how you put together the initial value proposition? Yeah, absolutely. So basically, where the formula that I like to start with the value proposition is, I like to start the beginning with showcasing the practice, who we are, what do we do, what do we provide, what is our experience, how are we different, and then I like to go into those case studies that I mentioned. It's always good to go through some of these case studies that you've had in the past, for example, where the patient otherwise would have presented to the emergency department. So let's take an example of that. Let's say you're an ENT physician and you keep slots open for patients that potentially would otherwise go to the emergency room. And let's say a patient, presents to your ENT practice with um, tonsillitis, and you can actually take that diagnosis and find out what the hospital would have charged for the exact same diagnosis versus what they would have charged or what you would have charged in your practice to take care of that patient. Um, so that's a good example where we can put an actual value on what you're actually providing uh, to the insurance company, an actual. Let's see, how quickly do you recommend jumping to actual cancellation of contract in order to get them to negotiate? Very funny. That's the second time I've been asked that question this week. And it's, another good question. Anytime that you have the flexibility to terminate your agreements, you're going to see uh, a lot more responsiveness. from the health plan, because again, they have to alert all their self-funded plans that they have a termination on the table. So anytime that you feel that you are comfortable enough, and some practices aren't always very comfortable terminating, which, I get it. But look at the way that hospitals negotiate. They come to the table and they say, this is what we're asking for, and we're willing to terminate. Sometimes just having that willingness to terminate will get you ahead of the line in the negotiation process, especially if you're such a valuable and valued part of their network. So I I can tell you this: our negotiations sometimes take 6, 8, 12 months, sometimes longer. Anytime that we can actually terminate, the negotiations typically only last 30 to 90 days. So that just tells you how valuable terminating as a strategy is. All right. Question. I run an infusion company, and Aetna has a new policy going into effect stating that instead of buying and billing the drugs, I must procure them from one of their specialty pharmacies. Can we negotiate this into contracts that we must be allowed to do B&B? That is something that you can negotiate. Buy and bill, yep. And I would probably get in touch with my rep and explain why you use the sources that you use, and why you're not willing to use who they're recommending as a vendor. How often do you go back to the insurance company if they refuse you? Uh, we will continue to go back to them um, almost limitlessly. Uh, uh, and part of that is, you know, really when we see that a client's rates are much lower than what the market can bear and what their competitors are getting, then there's no reason for us to continue to go back at them until they do the right thing and get us to what is a more appropriate market rate. Right. Are there any other questions that we can possibly answer? Well, awesome. I mean, you guys have been a very interactive audience. I greatly appreciate it. I love all these questions. We love helping practices negotiate their reimbursement rates. Again, if anybody would like a free consultation, would like us to pull your rates and give you a comparison, here's the QR code so that you can do that, or you can email Cameron at njhealthcare.com. But again, I greatly appreciate talking to you all, and thank you guys for all the questions and interactions.
Well, thank you so much. We appreciate all your time, Nathaniel. Thank you for your presentation. Thank you to all those that joined. We will be sending out the information here with this last slide with the QR code so that you know how to access that opportunity. We will also send out the link for the webinar recording to you all. And just want to thank you again, NJ Healthcare, Nathaniel, for your time. And to the Medpm members, feel free to reach out to us as you have a topic that's interesting to you, or something that you think we can support the group with. And thank you all for your time. Hope you have a great Friday afternoon. Bye-bye.
Thank you all.